Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we would like to ask you to complete. Your feedback is important to us as we plan future programs. So next, I would like to introduce you all to our guest speaker. Today joining us, we have Dr. Neal Chen. Dr. Chen is the Chief of Hand and Arm Surgery at Mass General, as well as an Associate Professor at Harvard Medical School. He is also the Program Director of the Mass General Hand and Upper Extremity Surgery Fellowship, which has trained many leaders in the field of hand surgery across the world. He joins us today to give a talk on carpal tunnel and other conditions related to numbness and tingling in the hands. So please join me in welcoming Dr. Chen.
Thank you very much, Amy. I'm going to start sharing my presentation here. So again, thank you everybody for taking time this afternoon to join me. I wanted to talk to you about carpal tunnel syndrome and some related problems. And I think that this will be an interesting area to learn about and to kind of clarify some symptoms that you might have. Well, we should start with a little story. So my mom called, and my mom lives further away. She lives in New Mexico. So she was telling me about all the different things that were happening at home. One was her neighbor's dog was barking a lot and it was keeping my dad up at night. And the kids are driving too fast in the neighborhood. But then she also told me that her hands are going numb. And so I figured that this was a pretty different thing. My mom usually wouldn't bring this up to me. So we started talking about what the problem could be, and my mom asked, what could this possibly be causing my fingers to go numb? And there's a few things to think about in this scenario. With regards to orthopedics or hand surgery, the diagnoses that we think about when the hands are going numb, especially at night, are carpal tunnel syndrome, cubital tunnel syndrome, and neck arthritis. And we'll go into detail about what all these things mean. But as we think about problems just in general with medicine, what we like to do is think about what are the possibilities and then try to narrow down what the answer is within that small set of diagnoses. So in order to try to understand this tingling and numbness, I think it's important to understand what causes the hands to go tingling and numb. And the one problem that tends to cause nerves to go numb is nerve compression. And a good analog to understand nerve compression is to think about nerves like wires. Wires have insulation, so they have this something that kind of keeps the electricity inside the wires. And then inside the different wires, you have different cables and different fibers that are sending information. So our nerves are very similar to wires. And we in medicine actually use the concepts about electricity and magnetism to understand nerves. And so when a nerve gets compressed, there's a couple things that happen. One is the insulation becomes poorer. Your body's insulation for the nerve doesn't work that well. And secondly, when you have compression that's kind of pushing on these fibers for a long time, more severe compression stops these fibers from working. And so we use this as a model to understand these problems. And when you have nerve compression and you're having these problems where the nerves aren't functioning well, that's when you get these feelings of tingling and numbness, especially in certain positions. The nerves in your body travel, they come out of your neck and they go down your arm past your elbow and down to your wrist. And they can get, the nerves can get compressed in any of these places when they're exiting your neck, when they're crossing behind your elbow, or kind of crossing at your wrist. And so carpal tunnel syndrome is a compression of one of the nerves at your wrist. And from this picture, what we can see is that you have this nerve, it's called the median nerve. And here in this picture on the left, you see this nerve coming down in yellow, and it travels underneath a ligament. And what happens in carpal tunnel syndrome is that this ligament thickens and it applies pressure onto the nerve. And what this nerve, this particular nerve, goes and gives you sensation to your thumb, your index, middle, and part of your ring finger. And when this nerve is having this compression here, you start getting tingling in the fingers that the nerve supplies. So we also like to show this cross-sectional picture of the wrist. It's as if we were taking your arm like a loaf of bread and slicing it right in this plane. And we see here, the reason why it's called a carpal tunnel is that basically you have this ligament and then these contents that are passing through this enclosed space. So the floor of this this area, this wrist, this portion of your wrist, are the bones of your wrist, but above it are some tendons, as well as the nerve. And the roof of this tunnel is this ligament, we call it the transverse carpal ligament. But that ligament gets thickened. And what ends up happening is that thickening reduces the space for all of these structures passing through this narrow space, and that compression causes you to have this tingling and numbness in the fingers. Cubital tunnel syndrome is a similar compression of a different nerve going behind your elbow. Cubital, it really refers to the elbow, where carpal refers to the wrist. And what happens here is, as this nerve, we call it the ulnar nerve, as it's passing down, going and traversing the elbow, there's an area behind the elbow where there's a ligament, and that also can get tight, and that puts pressure on the nerve. And this ulnar nerve goes down and gives you sensation to the small finger and part of the ring finger. So knowing those two entities, this carpal tunnel syndrome and cubital tunnel syndrome, you can figure out what's the problem by asking some questions. So the questions I would ask my mom would be, well, which fingers are getting numb? So if I know it's the thumb, index, middle, and part of the ring finger, I know that it's probably that median nerve, and it's probably carpal tunnel syndrome. The other things that are helpful are to know, what are the activities that are causing your hands to go numb? And are you waking up at night with this painful numbness in your hands? What I generally will see is that patients will have this painful numbness at night in patients with carpal tunnel syndrome. And so what we see here, when we kind of make a little chart to understand what are the symptoms we're going to see according to those questions, again, the fingers that are affected, you're waking up at night, because what happens at night is people tend to sleep with their wrists bent and flexed. And in that position, it pinches the nerve even more. So the ligament's pinching on the nerve, and then this funny position where you're flexing your wrists at night will pinch the nerve even more. People will also talk about when you're gripping a steering wheel, when you're holding objects, those things may cause your fingers to go numb as well. And that forceful gripping will add more pressure to the nerve. So when I hear those different elements, then I'm starting to think about carpal tunnel syndrome. Cubital tunnel syndrome, that compression of the nerve at the elbow, you can have symptoms at night because you sleep with your elbows bent. But then the activities that cause this to get your fingers to go numb are oftentimes keeping your elbow in a flexed position, like holding the phone or kind of leaning on a table. Those things will cause that ulnar nerve, as it's passing behind the elbow, to get pinched. And then finally, when we think about the neck, and we're not going to spend too much time on this, but just for completeness sake, the neck also has contributions to each of the fingers. So there's different levels of the spine, and there's different nerve roots that are passing between each of the vertebrae in the spine. And so the nerve roots have specific names. And so when we think about the arm, we think about the nerve roots C5, C6, C7, C8, and T1. And they go to very specific areas. So if someone says, well, only my thumb is getting numb as well as part of my forearm, then I'm starting to think about a C6 compression at the neck. If someone said, well, just my middle finger is going numb, but my thumb is okay, my small finger is okay, and I get a little bit of numbness of my index finger and my ring finger, it might be carpal tunnel, but it might also be the C7 nerve root. And that's what we're seeing here in this picture. The patients with the compression of the nerve in the neck, they don't necessarily have night symptoms as much. And the symptoms that they get oftentimes are positional with things related to their neck. So if they're turning their head to one side for a long time, you might get some numbness in a specific nerve distribution, but it's not the same as the carpal tunnel or cubital tunnel. The history also can tell you something about how severe the carpal tunnel is or the nerve compression is. If you're getting numbness once in a while, it's here and there, you probably don't have very severe nerve compression. But if you're getting constant tingling or your hands are always numb, that's more likely to be a more severe case of carpal tunnel syndrome. When you have really, really severe carpal tunnel or really severe cubital tunnel, you may see that the muscles aren't working well at all. So you have this loss of dexterity, or you might notice some weakness. So I go and visit my mom and, go to see her. I've been living far away for a long time, and now I'm seeing her in person. And there's a couple things with these symptoms that I'd want to pay attention to. So when I'm able to see my mom's hand in detail, what I'd like to do is, one, test which fingers are numb, test specific muscle functions to see that the muscles are working. And then I also want to see if there's any signs of muscle atrophy. And muscle atrophy, what happens is when the nerve is compressed for a really long time to a severe degree, what you'll see is the muscle will start to waste away and it'll start to shrink. And if you have enough wasting that even if you do surgery to allow more space to the nerve, sometimes that muscle doesn't come back. So those are specific things that we're really paying attention to. Again, there's an anatomy to all of these nerves, and we're paying attention to that specific anatomy. Here's another picture reflecting this median nerve and all these little branches that are coming up. And as you can imagine, again, if you're compressing the nerve in a certain area, only those branches that come off after that compression will be affected. This is another rubric of the distribution of the sensation of the hand that you'd expect to get numb with carpal tunnel syndrome. So this is an example of atrophy. If you look at your own hand, you'll notice that the thumb usually has a more normal contour in this area. But in this patient's hand, you can see that these muscles are sunken away. Why is that? Well, there's a motor branch, a part of the nerve that comes and feeds those muscles. And when that nerve gets compressed for too long, what happens is that that muscle starts to waste away. Here's another example of this. We call this thenar atrophy, thenar meaning the muscles of the thumb. And so one of the things that we're looking at as physicians is that if you have this thenar atrophy, it's telling us that this carpal tunnel is very severe. And it's possible that even after you do the nerve release, that you might see persistent tingling or even persistent numbness. We look specifically at the motor function of the thumb. One of the functions of the median nerve is to bring that thumb out of the plane of the hand. So it's bringing it up into the sky. We call this palmar abduction. And the other thing that your physician might do when you're getting seen for carpal tunnel is some special tests. And the idea is that these tests compress the nerve more than just kind of the usual day-to-day compression. It's more than the resting compression. You're trying to exacerbate the compression to make the symptoms kind of shine more when you're in the office. So this is called a Durkin test. What we're doing here is putting pressure on that ligament to smash the nerve even more. So you'll have more numbness in your fingers. So we can tell if this really is carpal tunnel. This is a test called Phelan's test. The key part of this test is we're flexing the patient's wrist in a way where it's going to add more pressure to that nerve. And so you should have more tingling in those fingers. And then the third sign that physicians will use is they'll tap on the nerve. They'll tap on that area where there's compression. We call it a Tinel sign. And then you might feel a little shock with that tapping, that percussion of the nerve. The cubital tunnel, when you're compressed the elbow again, you get this numbness of your fingers, but also there's some nerves that branch off where you get numbness of the back of the hand, as well as part of the palm. In cubital tunnel syndrome, that ulnar nerve, the nerve that's compressed in cubital tunnel, basically supplies many of the muscles in the hand. So when you have compression of that nerve, you'll see wasting of many muscles in the hand where you'll lose bulk in the hand, and then what you'll end up seeing is more bones, more tendons, but you won't see the small muscles, the bellies will have shrunken away. Some of the things that we look at for cubital tunnel, people have trouble crossing their fingers, they have trouble picking up small objects, they have trouble with gripping things. So both cubital tunnel and carpal tunnel lead to problems with dexterity, but there are different muscles being affected in both those situations. With cubital tunnel, we also have similar tests where you're trying to apply more pressure to the nerve. This is an elbow flexion test. You're bending the elbow and letting that ligament that's sitting on top of the nerve really squash that nerve. So those are basically the things that we're looking at in the office to try to clarify this diagnosis. Now, most of the time, if a patient has mild symptoms and we don't think they're very severe, we can try non-operative treatment. And the non-operative treatment for carpal tunnel syndrome usually is using a splint at night. And you can get these splints in many different places. They sell them at drugstores and the internet. If you're having a little bit of tingling and numbness in your fingers, some people will try wearing a splint at night. And what's the idea of the splint? Well, it keeps you from putting your wrist in that hyperflex position at night. So it's keeping your wrist in a straighter position, a more neutral position, and that reduces the compression of the nerve. Now, a couple things to remember if you're going to use the splint is don't make the splint really tight. If you're trying to stop compression, you don't want to wrap that splint tightly around your hand. And usually you just wear the splint at night. During the day, you want to be able to move your wrist around, move your fingers around. You don't want to wear it too much or your wrist will start getting stiff. A cubital tunnel splint is a splint that you put on the front of your elbow, and it keeps you from bending your elbow into that flexed position. Sometimes it's hard for people to wear these splints. So a pillow can be, sometimes an easy trick is to put your arm inside a pillowcase where the pillow's sitting in your elbow, so it prevents you from bending your elbow up. There's a lot of different splints like this too. There's things that look like knee immobilizers, the Velcro immobilizers people put on their knees. People have used them for their elbows as well. So there's all types of different ways of keeping your elbow straight at night. Here's another example. This is an arm pillow. Basically, you're just keeping that elbow straight in the evening. This is that example of that knee immobilizer type object. So if you have a patient where the non-operative treatments aren't working, or their initial presentation, it looks like they have a more severe carpal tunnel, we have a more thorough workup for them. And what we generally do is start with a study called the EMG, or nerve conduction velocity study. And this is the study where we're trying to understand the speed of the nerve conduction. We're trying to understand the strength of the signal that's being passed. And we're trying to understand, how much muscle is lost. This is really has been seen as the traditional gold standard for treatment of this problem. Now, we're starting to expand and use ultrasound to look at this, and more centers are adding ultrasound into their studies. And so ultrasound is a more comfortable test, but we're still unclear about how good that test is. So people think about EMGs, they think it's something like this, but it's not that bad. It's as if you're wearing a heavy sweater and you were turning on a light. You might get a little static shock. And at the very end of the study, they might take a small acupuncture needle to check your muscles. And from that test, the neurologist will make a chart like this. And the chart like this helps you understand the nerve function. And not to get into too many details, but what we're looking at, again, is how fast the nerve is conducting, as well as what's the strength of the signal. And again, it tells you what's happening to the insulation, what's happening to the nerve fibers. So it gives you an idea of how the nerve is functioning and how healthy is your nerve. So if you see that the nerve is slower, and you see that the nerve isn't creating the strength of signal that you'd expect, then you know that you have a problem with the nerve that you might want to look at or address. In the setting of this, to how we interpret these studies, as well as all medical studies, what we want to know is, what's the likelihood that you have this nerve compression? So if you're a patient, you might come from a demographic where you're more likely to have nerve compression and less likely to have compression at the neck, and kind of compression at the wrist is in the middle. Whereas you might come from a different group where it's more likely that you have the nerve pinched at the neck. So what we do is we take these tests and interpret it, looking at the population that we're getting the test from. So if you have a nerve study that shows that you have nerve dysfunction, we might talk about surgery or recommend surgery. And surgery, the goal of surgery is one of two things. One is to try to improve your symptoms. And then two is trying to stop the compression from damaging the nerve further and making the nerve worse. And sometimes patients have really severe symptoms where they're at a point where the nerve is very, very damaged, like the muscle's not working, the hands are not very dexterous. And we still talk about surgery in some of those cases because you don't want it to get worse, so you lose that little bit of function that's still working in that nerve. So sometimes you have surgery and the results, the the symptoms will completely resolve and your hand will go back to normal. But sometimes you'll have a situation where some of the nerve symptoms will resolve, but some of them will stay and be residual. It's because the nerve has been compressed so severely for so long that some of the nerve doesn't recover. So, we've kind of covered this already, is why do we think about the surgery and release? It's if that nerve compression is so substantial that we're worried that you're going to get long-term nerve loss. Here's a picture of a sample OR. It is the surgery, it's a day surgery. You're coming in for a brief amount of time and you go home the same day. So usually the surgery itself takes only about 10 minutes, but for our surgical centers, you come in a little bit earlier, you meet the staff, they make sure everything's safe, that you're healthy. And then usually there's two options for anesthesia. There's local anesthesia only, where it's just like going to the dentist. They give you some medication that numbs your hand, some lidocaine, and numbs the hand. And so then you're not feeling the incision, but you'll feel kind of people moving around your hands. The other type of anesthesia is you do the local anesthesia, but you also get some medication to make you a little bit sleepy, so you're not moving around during the surgery. And really, this is to the patient and surgeon's preference. And what do we do at surgery for carpal tunnel release? Well, we basically just cut the ligament. We cut this transverse ligament that we showed in those other pictures. And by opening it, it makes the space for the nerve so the nerve can try to get back to its normal functioning. The recovery, you can generally return to the light duty the next day. If you do heavy lifting, you can't get back into things. So full recovery is about 4 to 6 weeks. This is what the incision looks like in general. It's about 2 centimeters in length, about 1 inch in length. And again, the things that we don't want you to do is do heavy lifting around the time of surgery so that that skin can heal. We don't have people submerge their hand under water or swim for about 3 to 4 weeks after the surgery. Those are generally the major limitations. We take the stitches out at about 2 weeks. What are the risks of surgery? The infection rate's about 1 in 1,000. There is a risk of getting a nerve or blood vessel injury. That is a risk when you're operating near those structures, but it's really uncommon. It's even less than getting an infection. Some patients will have some mild soreness of the wrist after surgery for a couple months afterwards. We commonly call it pillar pain, but it's this pain kind of in the area before you get to the palm. And it's from when you do that complete release and make space for the nerve, sometimes it irritates or aggravates the nerve. The outcomes, this is one of our most predictable surgeries. We would say that there's not many patients that will go for another operation again in the future. So there's not many redos. There's not a lot of complications. So the success rate is quite high. This is one of our most predictable surgeries. So going back to my mom, she was having some intermittent numbness at night. She had no atrophy. So we got her a wrist splint, and then she was able to sleep through the night. So I could go back to torturing my mom with this. So thank you very much for sharing some time with me, and we'll open it up for some questions.
Thank you so much, Dr. Chen. We are now towards the end of the session, so if you have any questions for Dr. Chen, please enter them in the chat. We have a question. Oh,
go ahead. I'm sorry.
I was going to, we have a question in the chat. Is it possible for a person to have both carpal and cubital tunnel syndromes?
Yes, it is possible for a patient to have both compression of the carpal tunnel and cubital tunnel. Sometimes we speculate that the pathology, that the problem that leads to carpal tunnel syndrome can lead to the thickening of the ligament at the elbow as well. So, and sometimes we do treat patients for both at the same time.
Thank you. Can you talk a little bit about the relationship between carpal tunnel and pregnancy?
Yes, so carpal tunnel can present in pregnancy. What happens is that you get some changes in your ligaments during pregnancy, as well as you can have some retention of fluid. And those two things can lead to compression of the nerve at the wrists. Carpal tunnel during pregnancy, oftentimes we're starting with splints, and we're really trying to get you through those symptoms, because once you have the baby, the carpal tunnel syndrome will start to recede and get better. Occasionally, patients will have really severe carpal tunnel syndrome, and then that's a situation where we will consider trying to release the carpal tunnel even during the pregnancy. But generally, in those cases, we try to minimize any medication. Oftentimes, we just do the local anesthesia only, and occasionally we'll have to do that.
Would you recommend ice or heat for that?
So yes, so for in the setting of carpal tunnel syndrome for pregnant women, or in idiopathic carpal tunnel syndrome, what I find is that you can use either one that makes your hands feel better. In the grand scheme of things, it probably doesn't change the pathology that dramatically that one is better than the other. So it's not really changing the compression that much. If you, from a scientific standpoint, some people would say ice would be better because it causes your blood vessels to constrict, but at the same time, you might be causing some of the veins to constrict as well. So we're not really sure what the overall effect is. And so what I tell patients is, if it makes it feel better, go ahead and do it. I think that either one's fine.
Do you have any tips on someone who experiences a little pain while gripping something, usually at the wrists or between the wrist and thumb?
Yes, so that oftentimes is another very common problem. It's called basal joint arthritis, or CMC arthritis. And what's happening is you get arthritis. It's very common to get arthritis at the base of the thumb, where the thumb bone kind of meets the wrist. And so when you're pinching and grabbing things, it puts a lot of pressure on that joint. Where we generally start is to use a splint. You can get an over-the-counter splint from the drugstore, one that kind of comes around your thumb and supports your hand. And that's a good place to start for that problem.
Thank you. Regarding cubital tunnel syndrome, could the compression of the nerve be caused by sleeping in a mattress that's too firm? For instance, might a softer mattress help?
So the answer is yes. So that's, and I have an interesting story around this, is that when I was a fellow, I was also getting some ulnar nerve symptoms, some cubital tunnel symptoms. And I was sleeping on my back on a very firm mattress. And over, thinking about it during my fellowship, I realized that there was a hard mattress pushing on the nerve while I was sleeping on my back. So, a couple things you can do. One is you can get a mattress topper. The other is you can sleep on your side, but you can get symptoms from that. And oftentimes it's because you're laying flat, you're putting your hands on your belly, and then the nerve is sitting right on that firm mattress.
Thank you. Can the ulnar nerve compression be muscle related between the shoulder and neck if it is not cubital or a cubital issue, or is it always a neck compression issue?
Yeah, so there's other rare entities where you're getting compression of the nerves as they're exiting your neck, but they haven't quite formed the actual nerves. We call it thoracic outlet syndrome. And it's something that we generally will look for the more common things first, because they're the more likely things to be able to identify on the nerve study. But if those things are negative, and we're pretty sure that it's not the wrist, it's not the elbow, unlikely to be the neck, then we start looking for those less common compressions in the chest or the arm.
Thank you. At what point do you start to recommend surgery for carpal tunnel? The splints help, but the wrists and thumbs especially get increased pain after doing things like yard work.
So there's some variation with this among surgeons. So what number one is, I think that if your nerve study shows that you're losing muscle, that you're having some effect on the muscle, what I generally will say is that that's a pretty strong signal to think about the surgery. And the reason why is that, to get into a little bit of an explanation, what happens is if the muscle starts losing its nerve input, your body will reabsorb the muscle over time. And once you have loss of muscle, once it's reabsorbed, it doesn't come back. So that atrophy is really problematic. So when I start seeing muscle changes on the nerve study, I recommend surgery. The other times that I recommend surgery, even if there's no changes on the muscle, is if that you have nerve compression that looks like you've lost a lot of insulation and the signal is very poor. That's also fairly concerning, where I start saying, well, we should start thinking about intervening earlier. So those are the kind of there's an art to it. There's a feel to it. But those are generally the reasons why we would recommend surgery more than non-operative treatment.
Thank you. We have a question regarding post-op. Can people generally drive immediately after surgery?
Yes. So at our surgical center, some patients who have local only will drive to the surgery and then have the surgery and drive home. So because you're not taking any narcotic pain medication, it's something that we do have some patients do. If you get some sedation, you won't be able to drive home. But those patients that get some sedation, the next day they're driving around, living fairly normal lives.
Thank you. Are there any specific hand or finger exercise that you would recommend for patients who are trying to control the pain caused by the hands conditions?
Yeah, so in terms of exercises, there's probably not exercises that change this compression that much. The reason why is because that ligament has just thickened, and there's the position that actually makes the most space for the nerve and the tendons is this neutral position where your arm's flat. So exercises generally aren't that beneficial in that situation. So when we send folks for therapy, the therapists usually are getting the patients a splint to really try to limit that motion.
Thank you. While we wait to see if there are any other questions people have, do you have any final thoughts you'd like to share with the audience?
So first of all, thank you again for spending some time with me. This was very nice to get to meet all of you. I think that all of these conditions of the hand, there's many conditions that are out there, and what I would say that the common thread of these different conditions is that you're getting a sensation that's outside of what you typically feel is normal. And so that's the warning sign to say, well, let's look into this and understand what's happening. Some of the problems that are generally fairly mild and they're easy treatments for. And if we get to them fairly early, we can reverse some of them so you don't have to go through surgery.
Thank you so much. I don't see any other questions in the chat, so I think it'd be okay to end a few minutes early today. Dr. Chen, thank you so much for your time today. We had a wonderful presentation. Everyone,
Great.
thank you so much for taking the time to join us. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded, so if you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Sorry. Thank you, everyone. Have a lovely rest of the day.